Okay, this session is dedicated to the SP elevation, myocardial elevation, myocardial infarction. We have some legendary intervention cardiologists from home and abroad as chairperson to glorify these sessions. First of all, Professor A.K.M. Fazlur Rahman, Professor of Cardiology, Bangabandhu Sheikh Mujib Medical University, and also the President of Bangladesh Society of Cardiovascular Intervention. Professor Tan Hue Chin, Director and Senior Consultant of National University Heart Center, Singapore, and President of Singapore Heart Foundation. Professor Dhiman Kahali, President of National Interventional Council, India. Professor Mohammad Abdul Wadud Chaudhry, Head of the Cardiology Department of Dhaka Medical College Hospital and Post Director of IPDI. We have some dignified panelists among with us. Professor Syed Ali Hassan, Chairman of Cardiology Department of Bangabandhu Sheikh Mujib Medical University. Professor Shahabuddin Talukdar from Evercare Hospital. Professor Mohammad Shafiuddin from BSMU. Professor Shakil Ghafoor from Rampur Medical College Hospital. Professor Sabina Hashem from National Institute of Cardiovascular Diseases, and Professor Sayyada Alia Sultana from CMH, and Dr. Prabodip Kumar Kormakar from National Institute of Cardiovascular Disease, Dhaka. Management of SP elevation myocardial infarction is especially a burning issue regarding the intervention cardiology. We have some brilliant presenters who will present their cases regarding this issue. First of all, I like to request Professor Mir Jamaluddin, Director of National Institute of Cardiovascular Disease and Secretary of Bangladesh Society of Cardiovascular Institute, should present his lecture. Sir, Professor Mir Jamaluddin, sir. Can you hear me, Professor Mir Jamaluddin, sir? Sure.
Mijal bhai, you have to unmute.
Yes. Are you hearing me?
Yes.
Okay, thank you. Thank you. Due to some unavoidable circumstances, we have disturbed. Sorry for it. My topic is ST elevation myocardial infarction. Where is the field going in COVID era? As because we are passing COVID era, and that is why the topics has come. Though we know regarding the COVID-19 outbreak occurred December 2019 in Wuhan, China. It's a zoonotic origin most likely, and WHO declares global health emergency in January 30, 2020, and pandemic on March 11, 2020. And this is the 7th coronavirus infection, acts on binding to angiotensin converting enzyme 2 receptor in lungs, myocardium, kidney, and GIT. And how deadly the virus is, you can't, you see, and in comparison study with SARS, MERS, and COVID-19, amongst all, you see number of countries involved up to today, 214, and total people affected all over the world, 35 lakhs, and mortality is almost 1 lakh. This is the statistics of all over the world, and the mode of death. Usually the 1/3 deaths are due to cardiac, and that is why we are concerned, and respiratory failure, then other problems like respiratory failure with myocardial damage or heart failure, myocardial damage and heart failure, and unknown. These are the mode of mortality of the cases of COVID infection. And in Bangladesh, you see there is peak around the June, July, and now it is declining. At least we are seeing the cases are less, and first death occurs in 18th March 2020 in our country, and then lockdown was done on 24th March, and total confirmed case in our country 37 lakhs and 163, and death 5,400, and recovered 28 lakhs. And you know how the cardiovascular system is affected by the COVID-19 infection by different way, making acute coronary syndrome, arrhythmia, myocarditis, pericarditis, pulmonary embolism, venous thromboembolism, heart failure, cardiomyopathy, cardiogenic shock, and challenges in cardiovascular services in COVID-19 pandemic, limited access to rapid testing, and thus limitation to a rule in or rule out algorithm in STMI care is still in our country. And most of the developed country, they also can't do the rule out and rule in algorithm immediately. Lack of availability of negative pressure ventilation, cardiac catheterization laboratories in the country. Most of the country, they have no negative pressure cardiac cath lab, and limitations of resources and healthcare personnel, and potential scarcity of personal protective equipment somewhere, unavailability of the facilities for primary PCI at all hospitals in the country, and limitations to transfer of suspected COVID-19 patients between hospitals for care. And let us come to see one case scenario. A young man of 50 years, young female of 50 years, diabetic, hypertensive, and came with the 3 hours chest pain, hypotension. She was in hypotension, and which may run to the cardiogenic shock, and history of recent travel contact with COVID-19 patient, and no history of fever, cough, or any other respiratory complaint. And so clinical diagnosis ST elevation myocardial infarction. So we have the several issues in this regards: admission in CCU or in isolation ward, protection protocol for attending physician and staff, primary PCI or fibrinolysis. If primary PCI, then what will be the cath lab and staff protocol? What about rescue PCI for failed thrombolysis or elective PCI? Every patient undergo RT-PCR or not? What should be the protocol for COVID confirmed patients with STEMI? And let us see the scenario planned for primary PCI, and with level 3 PPE for all Catholic staffs, and ensure terminal cleaning after primary PCI. And this is the scenario of the right coronary artery following this acute ST myocardial infarction after 3 hours. And primary PCA was done. A thrombus section on the left panel, thrombus section is done, and on the right panel, this is the final scenario before stenting, and this is the stent deployment is in progress, and on the right panel, the result of stent replacement. Shona jay? Hello, are you hearing? Is there any problem?
I can hear you well.
No, sir.
Okay, thank you, sir. And case scenario 2, 52 years, he is also a physician and came from Saudi Arabia and is presented with us to chest pain approximately 6 hours with dyspnea clip +3, and blood pressure was low, and he no history of fever, cough, or any respiratory problem. And this is the ECG on the right panel. And STEMI management protocol at a glance. This is the clinical guidance for the management of cardiology patients in the COVID-19 pandemic from Bangladesh Society of Cardiovascular Intervention. Here we have seen that STEMI, whether presented in OPD or presented in the emergency department, and diagnosed by ECG and history. And if the patient is on emergency, then If the patient is in emergency, then we found see whether he has any respiratory problem. If there is respiratory problem no respiratory problem, and onset is less than within 12 hours, more than 12 hours, then conservative treatment, straightforward conservative treatment. But if they come within 12 hours, then clinical assessment for fibrinolysis or primary PCI. And in this case, we have already told that there are deficiencies of deficiencies of cath lab, which is only for the primary PCI, or which is only for the COVID patients. These are the dilemmas, problems, and that is why in this case we also usually do thrombolysis and then pharmacoinvasive procedure as an alternative to the primary PCI. In my country, mostly where there is no facility of several in different cath lab, different zone, either first floor regular cath lab, second floor in the dirty cath lab. If this is possible, entry exit should be different, as well as this cath lab is different, and only then we can think for primary PCI. Otherwise, fibrinolysis and after fibrinolysis, we can do pharmacoinvasive procedure on the following day. By this time, report of the COVID may be available. And if the patient comes with OPD, then we should search whether he or she have fever, dry cough, respiratory disease, respiratory distress, history of contact with COVID-19 case, history of recent travel, sore throat, running nose. All these we should we should have to search, and then we shall have to see whether he is a COVID negative, confirmed negative, or COVID suspected. And accordingly, if there is risk factor is there, risk factor is there, we shall have to go for the subsequent procedure. Either if high risk, then we patient comes more than 12 hours. Similarly, this group of patient also go to the isolation, and subsequently by pharmaco. No primary PCI. If the benefit is more, then pharmacoinvasive procedure can be done. And how we have managed this second patient: immediate fibrinolysis done with tenecteplase, and later on, after 24 hours, you see the scenario. This is the scenario: LAD, long segment diffuse disease, and TIMI 2, and next we have done accordingly the primary PCI. We have given 2 stents, and on the right panel is the final result. That does all myocardial infarction due to obstructive coronary artery disease? No, though it is a small study, but it was found that only 18 patient was included, and out of which result was 67% had obstructive coronary artery disease, and 43% had non-obstructive coronary artery disease. So a large number of patients does not require primary PCI following myocardial infarction in COVID era, considering he or she is suffering from COVID infection. And categorization of the patient: emergent, elective or non-emergent, outdoor. Emergent require immediate admission, particularly this group of patients having primary PCI, having acute ST elevation myocardial infarction, and within 12 hours of the chest pain. Elective or non-emergent may defer admission in COVID era, and outdoor patient prohibit routine visit or attend local hospital for minor symptoms, or encourage telemedicine, as because whenever the patient comes to us, our hospitals and we the healthcare personnel are the most important person for disseminating the infection from us to patient, and that is why, as far as possible, patient should not come to the hospital if it is not clinically indicated. And it is found in America, USA, they have shown in one study that the presence of myocardial infarction, ST elevation myocardial infarction in the hospital has reduced up to 50%. And it was found that why this, is there any decrease incidence of myocardial infarction with this COVID infection? No, there is no relationship with COVID infection with ST elevation myocardial infarction, except sometimes this ST elevation myocardial infarction is due to COVID-19. If so, then why patient is not present in the hospital? And this is the opinion that most of the patient suffering from ST elevation myocardial infarction or acute coronary syndrome do not want to come to the hospital. They are telling that we shall die in the home rather we should not die with COVID-19 infection. Otherwise, the events is almost same from the previous and present. And clinical emergencies requiring admission and treatment, this is also part of our paper which we published. Acute coronary syndrome, acute heart failure, malignant tachyarrhythmia, life-threatening AV blocks, patients with uncomplicated Stanford type B aortic dissection, patients with acute pulmonary embolism, myocarditis, myocardial injury, cardiac tamponade, malignant hypertension. These groups require immediate hospitalization and treatment. And procedural emergency, here we also see coronary intervention, pacing, ICD implantation, CRT implantation, and others like aortic dissection. These are the acute emergencies. They should have to admitted and require treatment. Here you see the coronary intervention ranks the top. ST elevation myocardial, ST elevation MI with hemodynamic instability. It is very essential, and they should have to do primary PCI. And elective procedures that may reasonably be deferred, but for me, at the moment, it is almost 6-7 months, 8 months has gone. So still, if we remains away from the patient, and patient should remain away from the hospital, then our treatment strategy will fail, and accordingly, our ST elevation myocardial infarction patient or acute coronary syndrome patients, they should not get the appropriate treatment. So we have to invite them now that if necessary, come to the hospital. But if do not think your clinical condition is not very bad, then you can stay home. And these are the points which we wanted to defer from the beginning of the COVID era, but not now. This coronary intervention, valvular disease, pacing, routine pacing, ICD implantation, this is also depends on case by case basis. CRT implantation, ablation, and device. This we could avoid for the time being in the beginning of the COVID era, but not now. We should focus on rapid turnover of patients and follow-up. This is very important. If one patient remains 1 day more in the hospital, then he or she may have to suffer COVID infection from the hospital. And so, as far as possible, patient treated and send him to home. Essential consideration in cardiac catheterization laboratory, negative pressure ventilation is necessary, and proper protection of healthcare workers necessity to remain up to date. And this is the take-home message. Every cardiac patient consideration needs to be given so that all acute coronary syndrome patients get highest care along with proper safety of healthcare workers. In our context, fibrinolytic is the first. This is the story of my country. In our context, fibrinolytic is the first, should be practiced for STMI until availability of dedicated cath lab, and no NST acute coronary for NST acute coronary syndrome medical therapy.
Sir, sir, are you hearing me? Professor Mijan, sir? Hello?
Professor Mohammed Rashid sir, you can continue, please. You can
Yeah.
continue.
Thank you, sir, for your time-demanding and brilliant presentation regarding treatment of non-ST elevation MI in this COVID area. During last 40 years, we all of know that the primary PCI is the gold standard treatment for non-ST elevation myocardial infarction. Already Tan Hue Chin is saying that in his country, Singapore, there is a small country, there is all patients are getting the chance to get primary PCI. With our chairperson, Dhiman Kahali is with us. Dhiman Kahali? No. Then in our contest, our country, I like to request Professor Abdul Wahab Chaudhary to share his view that the pharmacoinvasive theory can the replacement of the primary PCI. Can we switch over to the pharmacoinvasive theory in this COVID area, or we should with the fixed with our primary PCI strategy?
Thank you, Professor. The point is that we do not have a very rapid test to identify whether the patient has COVID or not. That means we cannot also ensure separate cath lab, a dirty cath lab and a clean cath lab. We cannot ensure. In that case, we have to be sure with a test that will require around 24 hours to make sure that the patient is not a COVID infected. In that case, pharmacoinvasive is logically the best choice for us. And studies have shown if you can do it within first 3 hours, it's almost as good as primary PCI. And again, as a thrombolytic, if we can choose tenecteplase, which has been recently available in this country, we'll do much better. We are doing that with streptokinase that has a much less efficacy. That's one point we should be taking care. Yes, I'm in favor of pharmacoinvasive in this COVID era, where we are getting time to be sure that patient is not COVID infected, and we can take the patient as early as possible to the cath lab to ensure TB3 flow in the infraculated artery and take care of all the other lesions as needed.
Thank you, Dr. Wadud. Now I requesting Professor Dr. Chaudhary Hafiz Hassan for presenting his lecture. Professor Hafiz Hassan, why? You can proceed.
Are you able to hear me?
Yes, Hassan bhai, you can proceed. We are viewing your lecture and your voice also.
So let me see whether I can go to my slide. First of all, I wanted to thank the society for inviting me, and I'm going to focus on ST elevation MI and multivessel disease and the issues surrounding it. Let me share this case first. 61-year-old with the lateral wall MI, and we did take care of this OM branch, which was the culprit, and then we brought him back for the ostial LAD, as you can see, and it was not in the same index procedure. The patient presented without shock, and then before the discharge, we brought the patient back for the stage procedure, and this was the ostial LAD, 0.90 IFR, FFR 0.71, and then we took care of that. You can see the OM stent is good, and then the ostial LAD was taken care of. And second patient, kind of a situation what Professor Jamal was alluding to. This is 58-year-old with chest pain, and then this EKG, and you can see that there is the right bundle, and then sinus rhythm with ST elevation, but there is alternate PVC, and this was no surprise because the EKG wise, we thought that this is the culprit with LAD occlusion, but then we found this. So I call this in ST elevation MI without shock. However, there is a threatened vessel. If there is a threatened vessel, then we try to do in the same setting. This was very unusual that we had two occluded vessels, and we did not need any support. Patient was hemodynamically stable. We did that in the same index procedure, and with the right getting good result, then we go on to the LAD. We always talk about the bifurcating lesion, but I tell you, there is unmasked bifurcating lesion sometimes we see after opening the infraclavicular artery. And maybe that is another discussion, how you tackle that. A planned revealed bifurcating lesion is one thing, but suddenly we see after discovering an occluded vessel, we'll have to think about what is the easiest way to tackle that. In any case, good result and then good outcome. And you can see this LV gram. And then there is a real problem with STEMI and shock. This patient with multiple risk factors came in, ST elevation in the inferior leads, and then this is the EKG. You can see that there is atrial flutter, ST elevation in the inferior lead, poor progression in the R wave in the precordial leads, and then I'll show you the cath in a moment, and then you may tell me which one is the culprit. And then because of the shock, we did the right heart pressure. You can see the wedge pressure is very high, cardiac index low. This was the bedside echo before we shoot the coronaries, and then global LV dysfunction, pretty bad, no LV thrombus, and then we do this cath that shows the LAD as thrombotic lesion, filling defect, and then the circ is occluded, and then RCA is a chronic severe diffuse disease, and then the LV is terrible. So because of the shock, and then already escalating dose of inotrope, vasopressor is not a good sign. We unloaded the ventricle first. We unloaded with the impella, then we intervened. We got the circumflex flow, and then the question comes in that whether to do multivessel complete PCI or not. We'll talk about that in a second. In this situation, we did it. So the literature says currently that unlike almost like 5, 8, 7 years ago, we now realize that there is really a definite benefit of going after the non-culprit lesion when we deal with multivessel disease and STEMI. About 1/3 of our cases with STEMI can be with multivessel disease, and it is important to treat them and ask for complete revascularization if possible. Why? Because in the complete trial, if you look at culprit only versus complete revascularization, there was a significant benefit in terms of reduction of composite endpoint of cardiovascular death and new MI. This Kaplan-Meier curve is important because what we did in the early part of the hospitalization, discharge, and then stage PCI within average median of 23 days, that early intervention for the non-culprit artery actually translated into a real benefit over time. If you can see, there is a separation of the Kaplan-Meier curve even 3, 4, 5 years. This is very important. And there is a significant difference between a stable coronary artery disease, mid LAD 70%, never had MI, versus a patient who presented with inferior MI and a 70% prox or mid LAD. That biology is probably different. And if you look at the complete trial, the subset group of OCT, there was higher number of thin cap fibroatheroma, what Dr. Renubani described as the vulnerable plaque. This patient's biology probably different, already sustained plaque rupture and then an event, and now with a non-culprit that is not benign. So the complete trial also looked at whether we do this in the same index hospitalization or after discharge, but within reasonable time. Median was like 23 days, and the groups were similar. But if you can see this in this index hospitalization or a stage PCI, we see the same Kaplan-Meier separation of curve favoring reduction in composite endpoint of cardiovascular death and MI. To answer the question, Professor Mir Jamal said that how you decide, and my sort of take on this, if the vessel is threatened and you can do this safely, we'll have to think about, yes, contrast load, radiation dose, but still, if it is a threatened vessel, probably better. If you can avoid to do this in the index procedure, probably think about hospitalization, or maybe after discharge within reasonable time of 2 to 3 weeks. So that's about the complete trial. However, if you look at that in the meta-analysis, we are seeing this same thing included in the CB-PRIT, the complete trial, the DINAMI, PRAMI, all favoring that. However, what I was trying to say that in cardiogenic shock, we relied on the meta-analysis, maybe favorable, and then this culprit shock trial came out, and clearly this is about 350 patients in each arm, showing that if you divide them into groups with culprit vessel only versus a multi-vessel PCI, then clearly the culprit only is favorable, and the renal replacement therapy, also the culprit vessel only is favorable. However, a very small number was receiving the concept of unloading first. That is something we'll have to wait and see how it pans out in future. So in conclusion, I would point out that when we are dealing with or challenged with STEMI with multivessel disease, it is important to make sure right off the bat that this is shock or without shock, whether there is any mechanical complications or there is anything that we don't see a good prognosis, then without shock it is easy. Do the culprit vessel. If there is a threatened vessel, you may need to do this in the index procedure. If it is not, then probably better to do the index hospitalization. That will depend on the logistics, resources, etc. Stage PCI within 3 weeks. If there is a shock, then it is better to do everything possible in terms of supportive care, and maybe in future we'll have to think about how to unload and target this with culprit PCI, and maybe the complete revascularization versus PCI to weigh in that situation. I will stop there and probably take some questions.
Thank you, Professor Hafiz Ahsan, for your elaborating and brilliant presentation. Then, regarding the multi-vessel PCI in acute ST elevation myocardial infarction, CRAMI trial and COMPLETE trial shows that multivessel PCI is giving the more beneficial results regarding the MACE, that is cardiovascular death and myocardial infarction. And I ask you, that is already you mentioned little bit, that is the Dynamic trial and Compare Acute trial shows that FFR guided PCI can give the better result in multivessel PCI. What is your opinion regarding
You look
this
at the,
using the FFR guided PCI?
yes, you notice that in one of my case I did this IFR, and by the way, if the IFR is on the fence, I usually do the FFR as well. But in the complete trial subgroup, IFR or FFR physiologic versus 70% diameter stenosis, that did not show any difference in outcome. So
Okay.
these are really important issues compared to stable coronaries.
ব্যান্ডেজে প্রোলিন মেশ ওখানে বললে হবে পোড়া কাটা পোড়ার ব্যান্ডেজ আলাদা পাওয়া যায় ঠিক আছে দোকানে বললে বা ওরা
Thank you, Professor Hafiz Hassan, for your answer. Now, Professor Tanhue Chim is with us, sir. Professor Tanhue Chim. Now, I like to Professor Saidur Rahman to present his case. Professor Saidur Rahman?
Yeah.
Are you with us? Yes.
Yeah,
we are hearing you.
ভালো আছেন
Sir, please you present your case.
স্যার হচ্ছে তো
Let's see.
হ্যাঁ অফিস হয়েছে
I think my slides are visible. Dr. Cesar, my slides are visible.
It's very well visualized.
Saidur, we are
Yeah.
viewing your slide.
Okay, thank you. So after all this, in the very early morning with an television MI lectures, means always you are burdened with some huge crisis moments all the time, and especially elevation MI with large thrombus burden. Okay, it's the devastating situations, like what is told that 4 specific things which can sway an intervention cardiologist is the calcium, the severe tortuosity, the high thrombus content, and the diffuse atherosclerotic burden. And among them, this high thrombus content, especially in primary PCI setting and ST elevation MI, is like a huge headache. And that's why we have to know 3 charts or 3 things to remember. One is what
Your is very
sound volume is low.
Yes, Saidur.
enhanced sound.
Saidur, you proceed.
Yeah. Now can you hear me well?
Yeah.
Okay. So these 3 things are very much important. Here's the myocardial blushing and also the TIMI flow. And among these 2, always we have to remember that only the establishment of TIMI3 flow in epicardial coronaries, in primary PCI setting is not sufficient, which we usually feel very great after doing a primary PCI. But if we don't see the blush grading, because distal embolization and microvascular obstruction has much more impact on myocardial perfusion. That's why the blush grading is very much important to understand and also assess. And the last, we have to understand the thrombus, how much thrombus you have. And we are dealing with the huge thrombus burden, and that's why we are telling that this 3, 4, and 5 scale, that means that almost totally occluding the thrombus prior to the wiring or after wiring, you can understand that these are huge thrombus burden. And deal with this thrombus burden is a very tricky dilemma, because this huge thrombus burden in HTMI may lead to a pretty complicated scenario using index primary PCI. like slow flow, no reflow in filtrate lesion. In stenting may not be effective due to cross distal embolization with MB0 and ended up with raised mortality, increased MACE, and also increased heart failure, retrograde embolization, and also increased risk of stroke. And that's why a bit of pathology we'll have to remember. There is the thrombus composition, the lesion length, the vessel dimension is very, very much important also to understand. And because gradually the platelet predominant thrombus becomes fibrin-rich white thrombi and becomes much more sticky. And especially when it's mixed up with RBC, that means it's going to be a red thrombus, especially in RCA and SBG, it's much more devastating. And that's why we see, before we are going to another discussions, we will see the two real-life STDs in STMI. This is one with a 56 years male with the anterior MI, and you can see the visible thrombus in the LAD and in the ostial LAD, and also covering also in the distal left main. And you can see the grade 5 thrombus here. Another case is the graft, and you can predict that obviously the thrombus will be more in the graft, and that's true. Coming to this, we have to understand that what are the options here. Like we have got mechanical and we have got pharmacotherapy to just fight with this huge thrombus burden. If it's mechanical, we have thrombectomy devices, which has been told by Dr. Khan also, some manual thrombus aspiration, rheolytic thrombus aspiration, angiojet, and also in Habib-Weiss areas, there is penumbra, which we don't have. And embolic protection devices, also we have distal and proximal protection devices, and stands especially dedicated for the large vessel STMI with huge thrombus burden, like M-girdle stentis, and also in some cases, LCAP or the laser therapy. And for pharmacotherapy, we have the broad classifications. We have the antiplatelets like the COX inhibitor, P2Y12 inhibitor, and the GPI like thiropivan, abciximab. And also we have anticoagulants like unfractionated heparin, low molecular heparin, and vivaluridine. And thrombolytics, we have IC or others, and we have also vasodilators and also the high dose statins, you can tell. But there are controversies and there is also guideline differentiations there, also which one will take or which one are not going to take. And an arbitrary chart flow, if you want to just treat this huge thrombus burden, then we can see that wire has been passaged, and then we have seen the grade 0 to, it's very easy, so we can go for direct stenting or balloon stenting and it will be solved. But if it is a thrombus grade 3 to 5, then we have no ischemia or tiny 3 flow is there, but even despite of this thrombus burden, then we have to go for the GPI and the BSCI. And if we have ischemia and TIMI3, less than TIMI3 flow we have, then we will go for thrombus aspiration, or sometimes laser not available here in our country, the direct stenting or balloon stenting, or the taking the M-girdle stentis, embolic protections, that is questionable, and IC thrombolytics also, it's also questionable, not in the guidelines. And what we have, ultimately we'll go for downstream GPI inhibitions maybe, and we also consider the risk of embolization, like we have to take mechanical supports, branch protections and everything, and ensure adequate oral antiplatelets very much, and also the upstream things. Of course, controversies are there, what to do with the guideline, what the guidelines are telling. The 2017 guidelines, sorry. Somebody is interrupting my thing. Can you hear me?
Yes, Saidul, we are hearing you.
Yeah, but the wider screen, the slideshow is not coming. So I don't have the slideshow here. So of course the controversies are there. In 2017 guideline, they have changes the recommendations and downgrading something and upgrading, like like you can tell the thrombus aspiration has been plus 2p, and in 2018 thrombus aspiration has no benefit even they are telling, and this is because I'm not able to see the slideshow. What's the problem with that?
presentation
Yeah.
mode এ যান, presentation mode এ।
Yeah, I'm going to the presentation mode, but it's not. Somebody has interfered.
No, we are seeing this. We are seeing this.
Yeah, but not in the slideshow.
But Mr. Sadhu, we are seeing
Somebody.
your slide.
Go ahead.
Saidul,
Yeah.
continue. We are seeing the slide.
Yeah, not in the slideshow. That's the problem. You can't see the moving things.
Yes, you can't see moving things.
Can I share again?
Yeah.
It's my
Okay.
sharing. Yeah.
Share again and forward.
Yeah. Sorry for the technical glitch.
Okay, forward, Saidul.
Yeah, sorry. So you are seeing now?
Yeah.
Okay. So for thrombus aspirations, what also can also elaborate a little bit, like in PUDMI trial, test trials, and total, they are not getting any benefit. But in spatial situations, like in bailout situations, with a huge thrombus burden, the TAPOS trial is telling that, yeah, it's beneficial because you have to do it very effectively, which is very much important. And so, how did we treat that two cases which I have shown before? That first one, which I told that huge thrombus in the proximal and the distal left main, which you have shown, you've seen a large filling defect is there. And of course, by the transradial approach, and the manual thrombus aspiration thrombectomy was done by the diverter. Still, what you see is that the thrombus has been embolized. Yeah, somebody stop. Yeah, say, still obtruded and obtruding this LCL from the shortest one. So we have to give the IC bolus administration of GPI, and then we have gone for the stent promptly in the LCH. Then after that, LCH is managed well, notice your thrombus descent, and then we have gone for the LED, which has been wired and ballooned, and then later on, it was not that, didn't create that much problem, and LED was stented by TESS, and after stenting, you've seen the final angiography shows the successful revascularization of LED and LCH with at least immediate free flow. And the next one is the SVD case, which I've shown the huge thrombus burden was there in transradial approach. And then we have seen that we have gone for we have wired it, and we have done the thrombus aspirations there. And then the thrombus has been well extracted, you can see here. And by just dipping the catheter deep into the artery itself so that the retrograde thrombus embolization is prevented a little bit. Then we have done the direct stenting there. And after that, the flow established, post dilatation was done, and a beat slow flow was there. And that's why the GPI was given, and then Dimitri flow has been established again. But last but not the least, that can we differ stenting in selected primary PCI scenarios? Not yet in the guideline, and not it was 3 in the guideline. But there are some trials, smaller trials, like DEFER STMI trial is telling that, yeah, sometimes in a huge thrombus burden, DEFER stenting in primary PCI reduce no reflow and increase myocardial salvage. So the dynamic 3 DEFER and other trials is not telling that one. But if you see this case, it's a 60-year-old man with a TMI and 3 year, huge thrombus burden LAD, including the LAD. Even after wiring, you can see that huge thrombus. We have taken the guide catheter, we have wired it, then pre-dilated it, didn't help. Then we have done the thrombus aspiration, didn't help. So took the help of long-standing study, with 38 millimeter, a bit restoring the flow. But when we have gone to the culprit lesion proximally, then we have stented it. Then again, resistant thrombus is there, and no flow has been. Again, to me, zero flow is there. And post-dilation was done, IC vasodilators are given, intracoronary epiphytic was given, microcatheter distally. Still, no TV3 flow was established there. So, should we have deferred stenting from before? It's not possible because it's not in the guidelines. But sometimes this sort of resistant thrombus is really something we have to think that what else we can do. The conclusion is that like this thrombotic high thrombus burden cases, primary PCI with this thrombus burden, a huge headache. The desperation and cocktail of adjunctive measures pretty obvious in catalog, and still huge mixed rotated thrombus in large epicardial coronaries end up with some suboptimal PCI results. Thank you very much.
Thank you, Professor Saidur, for your nice and challenging case presentation. We have distinguished panelists among with us. Professor Soed Ali Hassan, sir, are you with us? Soed Ali Hassan, sir? Then Professor Shahabuddin Talukdar? Professor Shahabuddin Talukdar? And then anyone of the panelists, distinguished can give your remarks or share your views regarding the presentation of the Professor Saidur Rahman. Professor Syed Alia Sultana, Dr. Pradeep Kumar Kormokar.
Thank you very much. It was a great presentation.
Yes.
It was a great presentation, as I must say. Thank you for your nice, elaborate presentation of this topic. Thanks again.
Now, I am requesting Professor Wadud to share his view regarding the routine thrombus aspiration in case of primary PCI. There is a total trial and test trial showed that the routine thrombus aspiration is not benefited for the patient of primary PCI, especially for the development of the cerebrovascular problem. Can you share your view, Professor Wadud?
I think the guidelines as stated is very clearly. You should not go for routine thrombus. But when you have a huge thrombus load, you cannot, but you have to go for thrombus aspiration. So, it's common sense. And as Saidur have shown, we have to think individually in a particular case. Should I go for direct stenting or should I go for thrombus aspiration? That will depend upon the load, the vessel involved, whether it's a saphenous vein graft or the native vessel. All this should be taken into consideration. Saidur, do you have any comment on that? Saidur, unmute.
Professor Saidur?
Yeah, what I'm telling that in real world scenario is really different what the guidelines is telling. Because sometimes really before doing the primary.
Saidur, unmute. You are muted. Unmute.
So in real world, when you are not wearing the case, me. So in that case, without wearing, you cannot predict the thrombus burden that much. You can predict a little bit, not that much. After wearing, you can understand whether that thrombus is so much resistant, insistent or not. And while wearing that one up, It's really individual interventionist discretion that what you will do. But whatever you were thinking at that time, even whatever the great intervention cardiologist you are, because that's such a naughty thing is there. That one, whether you can by manual thrombus aspiration, IC, GPI, IC thrombolytics, everything you can give, and you have to always rethink again the reperfusion injury. Because whenever we are giving this sort of IC, GPI, IC thrombolytics to solve, because we have to solve that problem. But we can't also all the time because reperfusion injury also making the patient miserable. So we don't.
Actually, I was want to talk. Actually, the thrombus aspiration is type 3 indication. Type 3
that's
it has two part. It's two part. One is no benefit and another is harmful. This category is no benefit. It is not harmful if you aspirate the thrombus. Another thing we usually do in primary PCI, if after the OR pass, if I see the landing zone, then I go for direct standing. If I don't go not sure about my landing zone, distal landing zone, then I should go for the aspiration.
That's we are doing sometimes like because that's the easiest way to go. But after standing, you can see that there is no flow even in the stand, no reflow.
Yes.
That's the dangerous thing. You know that already you have stunted that one. Then you will have to go for manual thrombus aspiration. Then you will have to do all these things. Already you have done it. But no reflow is there. So that one is very much dangerous. And that one is really creating problems sometimes. Once in a blue moon, but it's when it creates problem, like the primary PCI becomes because it's such a bit, especially in case of right coronary artery, these problems are very, very common because of red thrombus.
Yeah. Okay. Thank you, Professor Saidur, for your nice. Yeah.
So,
hello.
Sir.
Yeah.
So it's Hafiz Hassan bhai.
Just one comment.
Sir, I like to.
Sir. Professor Mirjaman, sir. You can share your views, sir.
Professor Saidur, I have heard your lecture mostly, but due to my internet connection loss, so far I could not remember something, and that is why I have want to know. That is, you have very nicely told that epicardial TIMI3 flow is not the indicator of success of PTI, primary PCI. It's very important term. Whenever we see that LAD or LCX or RCA is clean of clot and vessel is running flow, flowing well with TIMI3 flow, then we can think that, oh, I have done great job. But it is not great job until and unless peripheral perfusion occurs. And here I like to tell us know if there is large thrombus burden, that topics we have given you, we have selected you as you are the master of it, and that is why we have selected it. I want to know a huge thrombus burden in LAD or in RCA, and we have done mechanical thrombectomy, that is, though it is class 3 indication, but it was said that routine use of thrombus section in primary PCI is class 3. That does not indicate that you will not be able to suck. That does not indicate. And accordingly, you have done, and we also do sometimes. But still, stent is given. There is no TIMI flow in front of the stent. What is the measure you have in your hand? I want to know it.
No, that's I'm telling. That's actually I was telling that. Like in my last case, even we have done everything, like manual thrombus aspiration, and then later on IC intracoronary by microcatheter, the GPI, and the vasodilators, and all the cocktails you have given. But still, the thrombus is just in the distal part where the perfusion is necessary. So then you can go for the downstream GPI for another 12 hours and other cocktails and wait for some miracles that if the patient will come out, because there is nothing else we have to do there, especially in the primary PCI setting.
Sadhu, in this case,
Yeah.
actually, probably sodium nitroprusside is the last option we have.
Yeah, you know that nitroprusside itself also that makes so much hypotension sometimes. Oh my God! And it's something because all cocktails you have given, and these cocktails are making everything much more miserable. Distal embolization is going on. Patient is bradycardic. That BT is coming and going. So these are the scenarios which you don't know actually how we can manage that one. Only believing in God, nothing else.
Oh, okay.
Can I get from Chaudhary Hafiz Hassan?
Okay.
Yeah, Hafiz bhai can enlighten us.
So I do.
Sorry, Hassan bhai?
Yeah.
Okay,
So-
you can share your view. Yeah. Okay.
So the couple of things on the thrombus burden. There are some unique situation, which is one is stent thrombosis, and one is the vein graft. So vein graft and stent thrombosis is different than native vessel thrombus burden. And then I usually wear, and then I usually balloon daughter before I inflate the balloon. I get a feel because one of the important things, particularly the younger interventionalist, you want to make sure that you are not in the dissection plane. It is very easy to go in the dissection plane in a thrombus milieu, and then you will be in a difficult situation. I usually don't use intercoronary TPA or 2B3A. I usually don't, but I use preemptive, like Chris White from Oshner. He does use this, that the preemptive cocktail, whatever you use for the microvasculature. And I totally agree with Saidur that myocardial blush grade, Dr. Gibson has shown this beyond TIMI3 flow. But there are few things like this, and this will go on. We'll always debate that should we do angiojet? We had angiojet, we don't use it now. We had manual aspiration pronto, we don't use that. We use penumbra, but I tell you, it is a problem with penumbra that TIA stroke is not uncommon. So we need to be careful. So balloon daughter, give adenosine, try not to, but if you need to, then do it. And definitely I don't go for routine aspiration. Be careful about stent thrombosis.
Okay, thank you, Hassan bhai. Now I like to invite Professor Amol Kumar Chaudhary to present his challenging case. Professor Amol Kumar Chaudhary.
Can you hear me, Professor Cesar? Can you hear me?
Yeah, you can proceed. স্যার আমি নিচ্ছি না, ওয়াদুদ মডারেটর হয়ে গেছে, আপনি বুঝতেছেন না? ওয়াদুদ ওখান থেকে এখন বলতেছে অমুকে বলো, তা আমি কি করবো?
Cesar, can you see my slide? Can you see my slide? Cesar?
Yes, we can see your slide. Yes, we can see your slide.
Thank you for give me opportunity for presenting the my cases and also topics. Before my presentation, first thanks to BSCI Executive Committee, including President, Secretary, and Vice President, and Mahmoud Rashid Cesar is moderating the session. Thank you. First, on the eve of Mujib years, I pay my respect to the father of nation, Bangabandhu Sheikh Mujibur Rahman. Then my respect to the doctors and healthcare who died in the COVID era in the ongoing pandemic. My topics is challenging during primary feature. I think this is the last topics of STEMI, and this is the robust presentation and summarize the. I think it is very difficult to summarize all the primary picture things in a short. I have no conflict of interest. What we do? Fire. STEMI means fire. Your house is on fire, and every second is crucial. The fire is spread, and your home will be destroyed. So minute means muscle in STEMI, and no need to very emergency need to extinguish fire as soon as possible. Content of my presentation is introduction about primary PCI, already said by previous presenter, and guideline algorithm says differ, but my main challenge is different challenges, case scenario and its management. Debate and issue about already is told some parts, and conclusion. What are the challenges? Versatile challenges during primary PCI already been discussed are not uncommon in daily cath lab activities. Challenges during primary PCI are defined that the catastrophe to contemplated PCI by device or used during primary PCI or vascular access complications. Challenges during primary PCI should be managed by experienced personnel, adequate logistic support, and perseverance. If we summarize what can happen, what are the challenges during primary PCI? Acute vessel closure by dissection, thrombus or severe spasm, no flow or slow reflow. Acute stent thrombosis is very common. Ventricular arrhythmia is very common. Transient hypertension, shock, and body arrhythmia is not life-threatening, but should be managed and diagnosed appropriate time, and appropriate intervention should be needed. But very potential dangerous complication is coronary artery perforation, but not uncommon. Coronary artery ER embolism and thromboembolism not uncommon. RV perforation with TPM lead is not uncommon, and vascular access complication is not uncommon in femoral era, but in radial era there is some compromise, and it is preferable. Radial route is preferable for primary PCI. Except this technical and clinical aspect, there is in my country and also this subcontinent, there is some socioeconomic aspect about the primary PCI. This is traffic jam. After chest pain start, what time patient will reach the hospital. Then the consideration of financial support. Then patient is in doubt. Then to reach the cath lab, it is the time demanding, and there is a lot of discussion about burden, thrombus burden. I think in this subcontinent, this guideline can be deferred for, because we are getting lot of patient, the huge thrombus burden. I think it will be getting first world country like Europe and America. They got this type of thrombus burden, what have been shown by Professor Saidur and Sinmin. All of you know this algorithm. I don't like to go detail. What is the dot to balloon time? What is the total ischemic time? Everybody will know the first medical contact to balloon time. But we like add to the COVID era, dot to balloon time was previously 1 hour, 60 minutes. But now the ACC guideline add 1 hour more if needed to prepare the patient for personal protection or other test like antibody test. So take another 1 hour for primary PCI dot to balloon time. So it is now 2 hours. Common challenges during primary PCI. We must know the basic, then prevention, recognition, and management. My first case, 50 years old man, known case of diabetes, hypertension, AMI inferior lateral, cardiac arrest. This is the cardiac arrest before DC shock. Presented with cardiac arrest due to VT and reverted by DC shock. Plan for primary PCI. Left side there is mild to moderate lesion, but right side there is 100%. All of you know. So primary PCI to RCA start. Coronary artery dissection was the first challenges in primary PCI. I think the dissection is everywhere, but it should be tackled very nicely, every cases, but otherwise we did not get the result. So consequence of dissection, what happened? Infarct of extension, myocardial infarction may extend, emergency CABG may need, even can death. How will tackle? Balloon or stent? But dissection was, in this my case was, dissection was tackled with stent, and pedalation was needed because it was very severe stenotic lesion, and for that reason during pedalation dissection happened, and it is the good last the final shot is very acceptable, and also there is also microvascular filling is also good. A second scenario, 42 years old man, history of hypertension, diabetes, chest pain for 8 hours, acute myocardial infarction anterior. What happened? We'll plan for primary PCI, having complete heart block or bradycardia. So, but in this case, there is the question already have been well discussed. So I go very short. Thrombosuction should be needed, and we did a slow flow and reflow managed by everything IC 2B3A receptor blocker and also adenosine. All of we know no flow and reflow the sequence is 12%, very high in primary PCI, and mortality rate at 8%. So all of we know the mechanism: serotonin, atheromatous microemboli, and severe spasm may produce the slow flow and reflow. I will everybody must know what are the drugs can be used, but very effective drug is glycoprotein 2B3A receptor blocker. So can you remember the first one and this one? This is the case, the no stent is needed. So what we did in our case is deferred stenting. Though deferred stenting is very uncommon nowadays in the era of death, but sometimes may needed. With only thrombosuction followed by 2B3A receptor and adenosine, there is no need. There was a critical lesion in the LAD and produced antiuremia, but patient is okay without deferred stenting. Case scenario 3, risk factor is there. No diabetes is there, but smoking, chest pain for 7 hours, antiseptal MI. So plan for primary PCI. But left system is there is a very hazy lesion in osteoproximal part of the left main, and I think thrombus with severe stenosis. Right side was okay. But when I proceed, patient developed cardiac arrest. This is very panic situation in the cath lab. Definitely, we did the TPM. Everybody should must keep calm and carry on. We did what is the could be the region we did, but cardiac massage or CPR was given, stent was implanted, but flow is not satisfactory to left main to LAD, and well, we must know what is the cause of arrhythmia in primary PCI. Stem itself due to and also due to reperfusion and ischemia during the procedure. So tachyarrhythmia, VT is the 0.4% cases, but it is definitely VF is also definitely cause of one of the death during the primary PCI. And there is also arrhythmia like bradyarrhythmia we encountered, I think, than VT and VF, less and not less dangerous than tachyarrhythmia. The case scenario 4, 55 years old gentleman, antiseptal MI. We did it in 2009, performing perforation during primary PCI. It's very dangerous if it happened during primary PCI. Very dangerous. Prolonged balloon inflation we did, but failed. Wait several times, several attempts. Then we collect. We have an cover stent. Then I think I can remember as there is some mismatch about the size, so it also failed. So this Chan Mia, I am seeing. I can remember his name still now. Very urgent CABG was done in the Ramajan in the late part of the office time in the surgery department, and patient rescue, and still he came for some follow-up. So management of pulmonary perfusion, hemodynamic support is first important in primary PCI. Volume and inotrope pericarditis already shown in my cases. There was pigtail, IIBP, and total and syrup perfusion very important. Reversing the heparinization, balloon occlusion, platelet sometimes can be given if there is a huge ACT time is very high, and embolization, coil, gel form, and thrombus if the vessel size is less than 2.5. If vessel size is more than 2.5, there is should be a graft stent. This is all of coronary perfusion, but remember immediate prolonged balloon inflation, discontinuation or reversal of anticoagulant, and treatment of vagal reaction. It is very so. This is my case scenario of the second case, air embolism, is almost in the radial area with the check angio of the opposite side. This is a radial artery, not the culprit artery. There is a embolism and produces slow flow and also symptom hypotension and bradycardia. And also stenting treatment is also other patient, but not same patient. There is also air embolism after stenting. So we can escape RV perforation, cannot discuss by anybody, but RV perforation due to TPM bleed is not uncommon. Acute stent thrombosis is not uncommon. After 1 hour of this patient, I can remember the patient again ST elevation and come to cath lab, again recath and show there is the stent thrombosis, and all measures should be taken, including thrombosection, and another stent was given, and lastly the flow was established. This is the thrombus, and a primary PCI issue, role of thrombus suspension already been discussed. There is a good case, successful thrombolysis. There is a very bad case already discussed, and this patient was died due to failed thrombus aspiration, and thrombolytic was given, but ultimately patient improved, then suddenly cardiac arrest developed and died. What guidelines said already shown, but I like to say the multivessel PCI in this era should be thrombus aspiration should be a bailout in this subcontinent. I will say it is, and focus update also in favor of bailout thrombosis. So procedural exposure of primary PCI, all of you know that primary PCI stenting in the new generation days, but routine thrombus aspiration is not recommended. Routine use of deferred stent is not recommended, and revascularization now in STEMA, a STEMI patient with multivessel PCI before hospitalization should be done in non-infractular artery. Already Dr. Hafiz said detail. What about the DAPT? Procedural anticoagulant have replaced the clopidogrel patient with primary PCI. What will be the choice of stent? Already discussed the DES era in their DES replaced by BMS, but should consider whether there is bleeding risk or a long-term continuation of DAPT is possible of this patient. If not possible, simple balloon dilatation and BMS should be given if there is any contemplated surgery within 12 months. So, STEMI in multivessel disease already discussed. There is a RCA inferior MI with anterior, and we did it in the same sitting and also discharged in the index hospitalization very nicely. So, the multivessel PCI already is discussed. So, the issue I think resolved. So, my dear chairperson and moderator, so my conclusion, challenges of the primary PCI have been decreased with routine use of intracoronary stent. However, abrupt closure, perforation and atherothromboembolism and stent regret continue to challenge the interventionist. Attention to prevention, recognition and treatment of these challenges are essential. Knowledge of recognition, management of these challenges are vital for favorable result. Knowledge of recognition of challenge. Experience, proper hardware and ideal cath lab support can overcome most of the challenges. This is my cath lab team, and thanks to all for patient hearing. Thanks for giving me opportunity.
Okay. Thank you, Professor Amal, for your brilliant presentation and a lot of cases, challenging cases. Now I request Professor Mir Jamal sir to take some comments.
Professor Michamal, you have to unmute.
Are you hearing? Are you hearing? Thank you. What I was telling, that chairpersons of this session has another important word. Here, Madam Fazilutun Manik, Dr. Dhiman Kahli, and APM Sohrabuzzaman. I have seen the Sohrabuzzaman has entered, And besides this, this session, out of these three chairpersons, they should have another work, meaning that those who are the young city presenter from now and onwards, not Professor Amol, he is the teacher. So without them, we have an award, first, second, and third, and which we have decided previously, $300, $200, and $100, first, second, third. From here, now, the next presenters will be evaluated. So the chairpersons and panelists, here there are panelists also, they should have to give the decision regarding this. And now Professor Fazlur Rahman wants to tell something.
Panelist can also have chairperson.
Thank you very much. Actually, not to make confusion, I think the chairperson of the next session, Professor Fazilatul Nasa, Dhiman Kahali, and APM Surabujjaman will take the decision regarding the three speakers to giving our challenging award. So I thank every speaker from the previous session for delivering excellent and time-honored lecture. Now I request the moderator of the next session, Professor Amal Kumar Choudhury and Khandakar Shohid Hussain, to keep in mind there is a Zumba prayer at 1:30. Yes. Thank you very much.
Thank you.
We are already 1 hour.
Thank you, our chairperson. We like to start our session, next session. Chairperson already told by our chair, our president, Professor Fazilatul Malik, and Professor Dhiman Kahali and Surabujjaman, and my colleague, Professor Khandakar Shohid Hussain, is moderate the session, assistant, and panelist is there, Professor Nazir Ahmed from Heart Foundation, Professor Abdul Qadir Akon from head of the department of Salimullah Medical College Cardiology Department, Professor Muhammad Mahbubur Rahman from NICBD, and Roisuddin Mandal from Rajshahi Medical College, and Salahuddin Ullube from NICBD, and Abu Muhammad Shafiq from United Hospital. Eminent panelists, we can start our session.
Amal, there is also another important panelist, Professor Dipankar Nath, in this session also.
Professor Dipankar Nath from National Hospital, Dhaka. I like to request Dr.